Psychological considerations for rehabilitation of the injured athlete. Injuries are a part of athletics. The fear of injury might cause negative views of participation in an activity that has a positive impact on health and well-being. Sports medicine is an inexact science, so this is something we have to learn how to deal with. Psychological processes associated with injury are an inexact science. The goal is to cure the body and the soul, treating the person as a holistic individual. Acculturation are stressors that refer to moving the athlete from familiar sports culture to the unfamiliar rehabilitation culture. The comfort zone for many individuals is lost. There is a coach and athletic trainer role reversal that often occurs. Sometimes the athlete can lose control of a situation, and they may find that they have an inability to progress. Athletes tend to have self-confidence and the ability to adapt to mild or moderate injuries rather easily. But with more severe injuries, patients may not have the sufficient self-confidence to be able to cope. More emphasis is being placed on mentally returning the individual to competition with the emergence of sports psychology. All athletes deal with injuries differently. Reactions may range from disaster to opportunity. High-caliber athletes may be emotionally and socially behind their peers due to the role that sports has played in their lives. Often they started at a very young age and have continued to participate at a very high level for a very long time. Many individuals have emotional control issues after sustaining serious injury, which needs to be addressed. Physical and emotional aspects of return to performance are enhanced or neglected by the physiological results of both elements. There is a psychological response to injury. Once the injury occurs, there is physical damage, but there is also an emotional or psychological response that occurs for many individuals. With the physical damage, we have physical fitness goals, and then we have a return to performance. We need to be able to determine if individuals have the skills and are ready to perform at a certain level. On the psychological side, with that emotional and psychological concern, we need to make sure that individuals are addressing the acceptance of their injury and maybe even addressing conflict with their concerns about return to play. This all should be done before the return to performance, otherwise injury may occur. The injury-prone athlete. There are patterns of injury versus injury-free individuals. Some psychological traits may predispose an athlete or a patient to repeated incidents of injury. These include individuals that are higher risk takers or may play aggressively. They may be reserved or even detached, tender-minded or apprehensive, overprotective, or easily distracted. They may have the inability to deal with stress and also the fear of failure or guilt over unrealistic goals. Stress is a part of life. Stress can be positive or negative, sometimes both. Negative stressors seem to predispose an athlete or a patient to injury. This may lead to the lack of attentional focus, which results in miscues on the playing field. Added muscle tension from stress can cause a reduced flexibility and motor coordination. Focus, we have a width and a direction. Under width, it could either be broad, attending to a number of cues all at once, or it can be narrow, attending to only one cue. With direction, we have internal and external direction. Internal direction is attending to feelings and thoughts. External direction is the events outside of the body. Life stress is also referred to as a global assessment or global stress. There is a life events survey for collegiate athletes that may help us understand how much stress an individual is under on a daily basis. There is also a social and athletic readjustment rating scale that we may be able to use to determine how they're adjusting to their injury. The profiles of mood is another tool. This is an inventory assessment of the recent moods, the past days or weeks of the individual. The profiles of mood. To conduct this test, you require a questionnaire. You will need to explain the test protocol to your patient or your athlete. The athlete will then read each word or statement and decide how they have been feeling concerning that word or statement in the past week and today. They will select an appropriate statement such as not at all, a little, moderately, quite a lot, or extremely to indicate their feeling. The athlete or patient will respond to the 65 words or statements on the questionnaire. These are all the words. The individual collecting the survey then will determine and record the athlete's mood state scores. The Profiles of Mood is an inventory assessment of recent moods over the past days and weeks, like we've just discussed. These include subsets, including tension, anxiety, depression, dejection, anger, hostility, vigor, activity, fatigue, inertia, and confusion, bewilderment. This can be used to measure mood states associated with injury throughout the rehabilitation process. You should expect a varying response based upon the status of an injury and where the individual is in the rehabilitation process. As a clinician, we must be aware of the ramifications of severe injuries with long-term rehabilitation periods. Intervention for stress reduction. What is our role as the athletic trainer? What's the role of our coaches? The need or want for counseling may not always be existent, and the athletic trainer must be aware of this fact. Athletic trainers now take more of an active role in the psychological aspect of injury and rehabilitation. Remember, it's not our job to treat everything on the psychological aspects, but it is our job to refer them to appropriate resources. Screening processes may be a valuable tool, particularly with larger, less centralized teams. Using buffers. Sport is often the positive aspect of an athlete's life. The athlete often responds better to interventions within the sports setting because it is less stressful environments in many cases. Buffers help to allay the symptoms of stress without dealing directly with what originally caused the stressor. Some examples of buffers may be progressive relaxation with or without imagery, aerobic exercise, diet modification, treatment of sleeping disorders, and even time management programs. Some different stress management techniques include abdominal breathing, relaxation techniques, and imagery. Abdominal breathing is a product of yoga. It's a simple technique in which the individual focuses on belly breathing. It is an effective tool for relaxation, stress relief, and even pain relief. We focus on breathing and tension that is associated with pain and injury, and we focus to breathe the tension away. Relaxation techniques. This includes progressive relaxation. This is effective in instances where sleeping, tension headaches, or general muscle bracing or tightness are the result of stress. This is the opportunity to control our feelings associated with stress and anxiety. We do this through deep breathing, voluntary muscle contractions, relaxation, and sometimes even imagery. There is a significant relationship between muscle tension and nervousness. This is the process of progressively tensing and relaxing muscles. This is the process of progressively tensing and relaxing our muscles voluntarily to help facilitate an associated relaxation. Imagery is the ability to create an experience in the mind. There are different types of imagery, including visual rehearsal, which relies on coping and mastery rehearsal. Coping rehearsal includes the visual rehearsal of potential problems and solutions. Mastery rehearsal includes the visual successful return to play. Emotive imagery rehearsal is the visualization of scenes related to positive feelings and praise associated with successful participation. And body rehearsal. This is visualizing our body healing. We need to be careful not to overwhelm the athlete with information regarding the injury process, though. Keep it simple. Progressive reactions depend upon the length of rehabilitation. Three reactive phases to injury and rehabilitation occur. There is the initial reaction to injury, the reaction to rehabilitation, and the reaction to return to play or participation, or the possibility of career termination. Other influencing factors include the coping skills of the individual, the past history of injury, social support, and personality traits. The time frames for injuries vary. Short term is considered less than 4 weeks. Long term would be considered more than 4 weeks. Chronic is something that is reoccurring, and termination would be something that is career ending. The reactions are primary and secondary, but patients do not all have the same reactions, nor do they follow the same sequence. Some psychologists have applied the Kubler-Ross's 5 stages of psychological reaction to injury. These include denial, anger, bargaining, depression, and acceptance. Sometimes this is known as DABDA, D-A-B-D-A. There's also a cognitive appraisal model that may be more appropriate. It focuses on an injured athlete's personal and situational factors and how they impact the cognitive appraisal of the injury situation. This focuses on the interpretation of the injury rather than on the actual physiology of the injury. Cognitive appraisal determines emotional and behavioral responses. Cognitive, behavioral, and emotional responses are interdependent and collectively influence the recovery process. Other factors also contribute, including coping skills, history of the injury, social support, and personal traits. Dealing with short-term injury. Remember, this is something that generally lasts less than 4 weeks and could be possibly only days. We need to set a return to play criteria. What is safe for the athlete to return to play? We can do this only once the athlete is physically and mentally ready for return to play. In these scenarios, we are often dealing with injuries that are fairly common and part of playing the game. There are several stages that individuals will likely go through. First is shock. The individual may be a little bit in shock that the injury cannot just be walked off. They need to recognize the fact that the injury is not just going to go away. Rehabilitation compliance is often compromised when the athlete expects return to play without treatment in a couple of days. The second response is relief. This is a secondary reaction that is not something major, or that the injury is less serious than they originally believed. Relief may be contingent upon the athlete and athletic trainer relationship. Impatience. Many athletes desire to move quickly through the rehabilitation process. We must make athletes aware of the phases of rehabilitation so that they do not move too quickly. Otherwise, this injury could become more of a long-term injury or even a chronic injury. And finally, optimism. This is based upon the confidence and the trust between the athletic trainer and the athlete. The athlete or patient must trust the assessment and the plan for the injury, but compliance of the individual is still critical at this stage. The intervention for short-term injury. Allow athletes to vent their frustrations, but remember, you do not have to become a whipping post. You are not the individual that is responsible for dealing with all of their emotional problems or their emotional baggage. Encourage the athlete to stay engaged with their team. An individual may have to come to grips with possibly losing their spot on their team, and they may also lose their best shot for accomplishing their goals. Unfortunately, this is not within their control. However, doing effective rehabilitation consistently is controllable, and that's something you can encourage them. Compliance with our athletes, especially ones who are motivated to return, is usually not a factor. The reaction to return to competition after a short-term injury. Typically, this is associated with eagerness and anticipation. The individual is ready to begin practicing and playing again. As an athletic trainer, we must understand that the individual may not return to play with the same pre-injury competence and confidence, and we must have realistic return to play plans in place for the individual. This will allow us to have safe and effective returns to play. Dealing with longer-term injury, rehabilitation time is going to last more than 4 weeks. This includes more severe and more difficult injuries, and it may be difficult for the athlete to handle. There is often a length of inactivity and a lack of progress with respect to the rehabilitation process. This is often associated with fractures, surgeries, second and third degree sprains and strains, and even debilitating illnesses. The reaction to long-term injury is often associated with fear. Fear is the initial response. We must allay fear with pertinent information and dispel rumors or horrible stories that individuals have heard from others. Anger is a secondary response. This can come in many forms and will be directed at many individuals. If an athlete in this type of situation gets angry, try not to take it personal. Their anger is often the reaction to the situation and is not necessarily related to an individual. However, it is most often taken out on the individuals that are closest to them, which may include the athletic trainer. The loss of vigor. This can be masked as depression. The lack of a usual vim, vigor, or vitality. It is understandable to express these feelings, but be sure that there are no signs of clinical depression. Clinical depression in an athlete warrants much concern. Signs and symptoms include loss of appetite, sleep disruption, withdrawal, change in mood states, and plans for possible suicide. We must monitor our athletes' full return and success. Failure upon return may be detrimental to the individual. We may need to inquire with the patient regarding the need or the desire to seek psychological assistance during this time. We also need to address irrational thoughts. If persistent and interfering, if an individual is having these types of thoughts, they may be persistent and interfere with normal daily life routines, and then psychological intervention is recommended. Potential thoughts may include negativity, perception of pain, re-injury, social support issues, or even performance concerns. Athletes may harbor thoughts of not being able to return to play. They may become self-destructive. The emotional reaction may be exacerbating the problem. Common sense and judgment may be altered with respect to the potential for healing rates. Finally, alienation. The individual may feel that the coaches and teammates stop caring about their status, particularly if they stop asking. Athletes and friends are too busy, and sometimes they're just not around. Or even at the collegiate level, they're frequently traveling. The social life for the individual consists of rehabilitation. The individual may feel neglected if daily activity does not center on their sport. As an athletic trainer, we can help our athletes to understand that often our coaches care very deeply, but they may not have the expertise in the injury process. Coaches and athletes may not want the daily reminder of that potential of injury. The injured athlete versus the team relationship. Friendships are often based upon the participation of individuals on the same sport, and they may become compromised after injury. Keeping our injured individuals involved in team activities is critically important for mental status and overall mental well-being for individuals that are injured with long-term injuries. The intervention for long-term rehabilitation. Avoid reasoning with anger. Anger cannot be challenged. We may need to try to work with the athlete to control their anger and determine the cause, and then together develop solutions. Serve as an active listener. Control the inner negative thoughts, which are detrimental to rehabilitation. This can impact the mental and physical performance. Try to instill a positive attitude. Work to restructure the thinking process. We must address negative thoughts. Integrate negative thought stopping. Work to facilitate positive constructive thoughts, concentration, cues, images, and calming responses. In combination with physical progress, patients can return more quickly if we do this. Restructuring perceptions helps patients to become more aware of destructive and self-defeating behaviors. Work to recognize and challenge irrational thinking. Irrational thinking can contribute to anxiety, fear, depression, illogical and distorted perceptions of events, or draw unrealistic conclusions. Work to replace social support with support groups. Work with athletes to answer questions. Athletes will question those imposing demands upon them, such as doctors, athletic trainers, and coaches. Show the athlete that you understand the importance of competition and returning to play as quickly as possible. Try to continue to be supportive. Attempt to reintegrate the athlete with the team through functional training and sport-specific drills when appropriate. Support from their team and teammates will be critical for the individual. The reaction to return to competition for long-term injuries. The primary reaction is acknowledgement that the rehabilitation process is complete. The athlete has successfully fulfilled the criteria to return to play, and they are physically and mentally prepared to do so. The secondary reaction is trust. Trust in the process. Trust the fact that they are ready to perform, and trust that they are able and can do what is expected of them. Dealing with chronic injury. Injuries with slow, insidious onsets are considered chronic injuries. These types of chronic injuries often start with the feeling of pain or signs of inflammation, but they may linger and last for months up to even years. These tend to be overuse types of injuries, including things like tendinitis, stress fractures, compartment syndromes, or other second or third degree injuries. The reaction to chronic injury. This includes anger, frustration, dependence, and independence, and a secondary response is one of appreciation. For anger, even with all the rehabilitation, the injury still lingers. The individual may become frustrated with respect to the return to play progress. Rest and inactivity are traditionally required, which may annoy an athlete who is used to participating. Frustration. There is a realization that actions may have caused the injury or reoccurrence. If sport functioned as a buffer, it may be absent for a time being. There is a possibility of no real solution that may become daunting for the individual. Dependence and independence. Individuals may fall into one of two camps. Either they want no control or complete control. They may also be reactive or proactive. Many individuals will be in either extreme. Either they're willing to try everything or there's no desire to try anything. Dependent athletes do not take ownership of their rehabilitation process. They will likely relinquish all power with regard to rehabilitation. Someone else should take the lead and ownership of the problem, in their opinion. They may demand time be spent with just them, which comes across as somewhat of a selfish attitude. An independent reaction is just the opposite. These individuals want to be in charge and kept abreast of the situation. These individuals may also search for the perfect treatment. Be careful of things like WebMD. The secondary response is one of apprehension. Many individuals are not certain the injury will ever heal. They may approach rehabilitation with trepidation and stress out over every sign or symptom. These individuals tend to worry when rehabilitation is not going as fast or is moving forward as rapidly as they would like it to. Let's focus a little bit on anger and frustration. If a dependent athlete does not feel like they are receiving appropriate levels of attention, the athletic trainer may need to explain time restrictions. The athlete's attitude must be pointed out to them as inappropriate. Then we can start to work with the athlete to become an active participant, not just a passive participant. We can work to develop trusting relationships and form a team approach. Rehabilitation needs to be a two-way street with mutually acceptable options. Effort should all point to positive outcomes. The reactions to chronic injury and recovery. Many individuals either become skeptical or they become extremely confident. Individuals who might become skeptical do not necessarily have negative thoughts, but it's one born of experience. Athletes generally make peace with the nature of chronic injury. Hope is tempered by the reality and the limited control of the situation. They may develop confidence on the other side. This is an unyielding faith, untarnished by repetitive setbacks. Often, this is a more global response by the athlete and not injury specific. Injury does not design and mandate their life. Dealing with a career-ending injury. It can be a very hard adjustment to make when an injury ends participation in sport. Sports end in different ways. It could be abruptly from something like an injury, or it could be a planned departure from something such as graduation or termination of eligibility. If unexpected, the goals may be left unaccomplished. It's a much smoother transition if an athlete chooses when to depart sport, as opposed to having it end early. Potential career-ending injuries may include things like spinal cord injuries, extensive hardware implants, multiple surgeries with declining benefits, and persistent debilitating or incapacitating illnesses. Some of the reactions to career-ending injury may include isolation, grief, and loss of athletic identity. Isolation. The athlete usually is defined as part of a team. Sometimes this becomes part of their personality or part of who they think they are. The nature of sport. There are exact boundaries with defined roles for athletes. When we have a termination of play, many people feel detached. There may be associated grief. This is the loss of the career and identity, extended family, or even their place in society. Sports end up being a community where they are productive members. There is a loss of comfort and it requires an adjustment period. The loss of athletic identity. This is a primary reaction to rehabilitation that terminates a career. The psychological adjustment of belonging must occur. This may be half-hearted when beginning a rehabilitation, and counseling may be required. Please, if you have somebody in this situation, determine if the athlete can work through this period of grieving or whether they need to be referred to others to help address this issue. Intervening in a career-ending injury. We may need to decide on an individual basis, and interventions can come in many forms, including psychological counseling, career counseling, and even financial planning. Adjustment is usually easier with extended careers. Sudden, unexpected injuries are more difficult to deal with due to the unexpected retirement. There has to be a process of closure and renewal. Closure is necessary to give renewal all the necessary energy. We may also have to consider professional athletes versus something like Olympic athletes. There may need to be an ability to adjust and prepare for a new career. Many athletes make better life adjustments when it occurs on their own time frame and when they're prepared for it. The goal of rehabilitation is return to activity. So let's talk about compliance and adherence to rehabilitation. The primary treatment involves exercise to retrain the muscles and the body. If psychologically the athlete is not focused or focuses on the injury too much, the ramifications for healing are detrimental and it may result in potential re-injury. Compliance is the obedience of the patient to the physician or health care giver's instructions. This is more passive than active. This generally applies to immediate short-term treatment. Adherence is the active voluntary choice, a mutuality in treatment planning. Sometimes this occurs more often in long-term or more voluntary care and treatment. This typically occurs when services are being sought out as opposed to being prescribed. We can either comply now or adhere later. The measurements of compliance. We can look at self-reported, attendance, and therapeutic outcomes. Self-report may include questionnaires designed to determine the level of compliance. This is self-monitoring, record-keeping. It may be inaccurate due to poor memory or trying to please an investigator or researcher. Attendance. This is the most common and direct method of compliance. This is not always an indicator of completion of rehabilitation, though, however. Therapeutic outcomes. These are not always reliable and could be impacted by confounding factors. So we need to be aware of that. All three can be useful in determining compliance of our patients. Some different factors influencing compliance. Athletes that are committed to rehabilitation work harder and return to play sooner. Athletes tend to be more self-motivated and have greater pain tolerance. There is typically support from peers or coaches and rehabilitation staff that is important. The attitude of the individual, the athletic trainer's perception, may be self-fulfilling prophecies with regard to non-compliant athletes. And our attitude could impact the athletic trainer's ability to motivate the athlete. Putting the plan in writing may make an athlete more adherent. This gives us an effective plan and a place to follow. Coaches must serve as disciplinarians and support in the rehabilitation process. Coaches must make rehabilitation a priority. Athletes will typically follow the sentiment of a coach. There is usually a reason for non-adherence. Does the athlete understand the process? And is there something else that's more important at the time? Motivation must come from within an individual. The lack of commitment may be an indicator of frustration or even boredom. Be sure to include the athlete in decisions. They may be helpful in athletes making commitments. Input and flexibility may result in more compliance. The role of the athletic ability or the level on compliance. And other factors may include the length of time at the institution, the individual's GPA, perception of class load, career goals, the amount of time in contest participation, the perception of available time for treatment, and the previous experience with rehabilitation, either positive or negative. Pain is a deterrent to compliance. Painful exercise can limit the healing process and serve as a deterrent to activity. While pain is somewhat subjective, the athlete's pain perception must be taken seriously. We must address the cause. If pain persists after adjusting rehabilitation, further evaluation is necessary. Pain must be assessed, monitored, and managed. Can the athlete play with pain? That's a good question to ask yourself. There's different types of pain: the pain of performance, the pain of rehabilitation, and the pain associated with acute and chronic injury. Pain can be assessed relative to intensity and quality. Factors impacting pain include culture and the type of sport. Using disassociation for pain management can be helpful. Have the athlete think about something other than the pain. Focus on positive images, such as favorite locations or experiences. Use activities that engage the mind, including visualization. Goal setting has shown to be an effective motivator. Athletes are typically goal-oriented, and rehabilitation should also be goal-driven, both short and long-term goals. The guide to goal setting: they should be specific and measurable, use positive language, be challenging and realistic, incorporate a timetable, integrate short, medium, and long-term goals, link the outcomes and the progress that is being made, and involve the monitoring and evaluation of goals and sport goals linked to life goals. Athletes must have a sense that the goals can be met through rehabilitation. Goal setting must be a joint effort. Athletes must take responsibility for doing the necessary rehabilitation. Additional motivating factors or buffers may include positive reinforcements when goals are met, time management for incorporating rehabilitation into their lifestyle, and feelings of social support. Return to competition. Playing with pain is often interpreted as playing through an injury. What we need to consider is an injury made worse, or will it just remain? Is the athlete more body aware than the general public? The general public typically has a desire to treat pain prior to return to activity, rather than returning to activity in spite of pain. The responsibility of the athletic trainer is to determine the appropriate return time. Problems arise when untrained personnel assume this responsibility. So, what pressure does that place on the athletic trainer? Athletes must be made aware of the difference between pain and injury. If an athlete continues to play with an unhealed or poorly rehabilitated injury, the chances of living a healthy life of physical activity is reduced. Most athletes struggle seeing past the present season. Some athletes with invincibility attitudes have difficulty adjusting to injury. We also need to consider who is making decisions regarding readiness to return to play. The athletic trainer is critical in helping to make patients and coaches understand the limitations associated with injury and its impact on playing status. Neglecting the injured athlete can contribute to injury or re-injury. Coaches should avoid this tactic, as it could be detrimental to athletes with severe injuries. Generally, coaches and athletes are frustrated by injuries. An athletic trainer should be supportive and work to gain the trust and the loyalty of both the coach and the athlete. Commitment is a two-way street. The interpersonal relationship between the athlete and the athletic trainer. Athletic trainers receive considerable training but have a limited counseling background. Referral to a sports psychologist may be warranted, so we need to know our limitations. We must deal with athletes as people and not just injuries. The care for the person should be holistic. It is not just because it's your job. Athletes must also be able to trust the clinician if they are going to be truly successful in the process. Communication is essential. Become an active listener. Listen beyond the complaining. Try to pick up on underlying factors such as fear, anger, depression, and even anxiety. Body language. Pull yourself away from the paperwork and engage in the athlete. Treat the athlete as an equal. This aids in the athlete's acceptance of responsibility for rehabilitation. Be aware of the athlete's change in lifestyle due to their injury. There must be a sense of genuine concern and good rapport with an athlete. It starts with the evaluation process. An athlete should have input from the start. Provide thorough explanations of the injury to the athlete, but at their level. An athlete's perception of the injury is critically important throughout the process. They must understand the injury at an appropriate level. Integration of sports psychologists can serve to facilitate the athlete's transition from sport to rehabilitation. This can help to assist an athlete into assimilating into a new environment with new rules and roles. Stress associated with sport can impact an athlete's compliance. Individuals are typically more successful if they're fully engaged in the process. Stress can be a deterrent. Psychologists may be able to engage athletes and use different techniques to reduce levels of stress, including relaxation, imagery, cognitive restructuring, and thought stoppage. This can aid the athlete in return to activity and adjust their perception of readiness. This can also be an effective link when an athlete is unable or unwilling to continue participation. Athletes may require assistance in their transition from sport to a completely different culture. It is important to remember that rehabilitation is not just physical, it is also emotional and psychological in nature. The environment, athletic community support, and culture combine to influence the course the athlete will take through the rehabilitation process. The sports medicine team must treat not just the injury, but also the extraneous factors influencing the patient.